and an oblique view, from my reading, was to look more at the pisiform, but I'm not sure if, and it's centered at the carpal, at the mid-carpal area. But then so the lateral wrist is something that's discussed between orthopaedics and radiology a fair bit. So from a radiology point of view, my understanding is that true lateral is when your metacarpals, the capitate luna and the distal humerus are in line, not necessarily looking at the view of the joint space, which is where the orthopaedic view is often what's wanted, particularly with our ORIFs, where we aim to try and see that joint line. So that's another area of complete disagreement, or no collaboration between the two groups, whereas the two views could be done in one shot, like this one here, where you've got the correct line up with the joint space as well. It's just that the request, when we always say get a true lateral, it doesn't necessarily mean that the radiographers are thinking the same thing. That's what I'm trying to say. Scaphoid views, so there's a range that are done. The PA with ulnar deviation, and the PA with, I believe that's the 25 degree of volar flexion as well. And moving on to the hip, so preoperative imaging for a total hip replacement. It's for a Charnley view. And our request was also for a frog leg lateral. But from a radiology point of view, the routine for all hip issues is a Charnley view, but they usually do a lateral oblique, which I'll show you what that is. So this is our Charnley view, which is centered, a central ray is centered on the pubic symphysis with the feet in 15 degrees of internal rotation. And the lateral oblique, which is the way, that picture's, sorry, being shifted. The lateral oblique is done with the patient with their legs twisted to the side, and the beam is directed towards the groin. So this is the way the radiographers are routinely doing the laterals. In contrast, we were requesting the frog leg lateral, which is more routinely done in paediatric population, and another option is the shoot-through lateral, which is, I guess, what we see in a DHS when you are going right through the groin, when you have your central ray running right through the groin. Oh, sorry, I did have a frog leg view, but it's disappeared. So there's a bit of disagreement between those two again. And then for preoperative total knee joint replacement, the request is for bilateral knees with independent weight bearing on each knee, and also within that to have one view with the knee in 20 degrees of flexion, and then focusing on the affected knee to have AP lateral intercondylar and skyline views as well as the long leg. From a radiology point of view, the routine that is done is an AP, and occasionally in the 20 degrees of flexion, as well as a lateral oblique and in a trauma setting, the horizontal beam. Sorry?
You don't need an AP view if you're doing a weight-bearing AP.
This is from the guidelines that I've taken, that are the protocols.
Okay, that's what I do in private too.
So this is our AP knee in supination, and the AP in a weight-bearing view, which, if requested, is done with each knee weight-bearing independently. This is the weight-bearing views in extension. With the
It was a metre from on the right, probably there's not that much erosion, but you can't really tell. You've got an on-way, you can actually better assess how much they don't actually take a few extra mils off the thing and do an usual.
And the second one that's done is in the 20 degrees of flexion as requested preoperatively, which I don't have an X-ray of, but this is how it's done. But the other thing that came up was Rosenberg views, which are occasionally done in other hospitals preoperatively, or are requested here as well. However, this hasn't been passed on to the radiography department, where if we're requesting Rosenberg views, I believe that their understanding is that it's in 20 degrees of flexion with a straight beam, and they're doing it as per our other common requests. So the actual definition of a Rosenberg view is in 45 degrees of flexion with the 10-degree caudal tilt of the beam. So
People with osteoarthritis might find if you're doing a uni with your weight bearing on one leg, might find or other.
Yeah, so this is not part of our protocol, it's just that it's occasionally requested.
They'll just stand both legs.
Yeah.
And then
Can I just make a point about the people doing weight bearing on both legs? The people who usually independently weight bearing something for the standing on both legs, because that can transfer in the weight of the body.
This is what I suggested to Rekha last night, that I personally, and like I said, my open person do it individually weight bearing. Even if the request is for bilateral knee, they do each one at a time. That doesn't always be but that's ideally what we would like to do.
And then the intercondylar views, the textbook method of doing it is with the knee up on a particular pillow with the cassettes, with a slide in for the cassette, but we don't have that here at Western Health. So this is the way it's done in our radiography department. I'm not sure if there's a difference in the outcome. And these are our laterals, which is also, this is the lateral views that are done standardly for a knee replacement surgery. And then we have our skyline view of the patella, which there's a range of different methods of performing this. And this was our protocol for post-operatively AP lateral, and then post-op at 6 weeks is for the full range of X-rays again.
Just so I go back to 6 weeks.
Yeah.
I put that down. Query, do it then at 6 weeks, or do you want to do it at 3 months?
Mm-hmm.
To discuss whether you did it at 6 weeks.
Oh.
Why do we need an intercondylar view test facility?
Because you may have submitted a file.
And a routine to submit, or should just submit that?
So when we get to I've got probably 6 weeks.
They usually stand comfortably at 6 weeks. There would be, is there a downside to doing it at 6 weeks?
Probably 3 months, they're really more the roster follow up is on you go.
Right, let's just 6 weeks.
Yep.
So what do you do with the result?
Sorry.
Why is it?
Why? Well, if we want to know if you want to analyse some,
Oh, for analysis, but
Yeah.
Outside of analysis, do you want it to be sent to?
No, it's basically, you know how we have the argument every week, we check the x-rays and we say there's no point checking there. So down the line we do studies and
Well, I
result
think the
arguments.
studies is good, but outside the studies.
Well, it's basically,
Just adds to the stress load if you like.
I'll leave it to put on your request, no
I'm just saying that I think that it's important to understand why you're doing it. Why we're doing it is not so much for that individual patient, because it probably wouldn't matter what it was. You're not going back and revise it in 6 weeks. But it's part of research, and I think
And the feedback to us is quality control.
Absolutely, but I think we've got to put situations in place where it goes into a research protocol.
Yeah, these are all about established. So when we do research down the line, we'll have a protocol that we can.
So just as a second modification for that is also that majority of knees that are coming through do not have the magnification markers on them at the moment. So I think that needs to be on our requests in pre-admission or in discussion with the radiology